Good afternoon, good evening, and good morning to those of our audience who are in Asia. My name is Jianan Yang, and I'm a postdoc here at the Asia House Policy Program at the Sharon Asia Pacific Research Center. Welcome to our second PKU Stanford joint webinar on Asia House policies this academic year. Before I introduce to you our speaker today, I would like to quickly note that our next webinar will be on the afternoon of December 8th or the morning of December 9th for our Asian audience. And we will have Dr. Chirantan Chatterjee from the University of Sussex Business School talking to us about the pharmaceutical economics, biomedical innovation, and global health beyond COVID-19. I think we have, or we will put the registration link in the chat box, and I hope to see many of you there. And you can also subscribe to our newsletter to be updated about our events on the Asia House Policy website. And so today we are delighted to have Dr. Ariel Zucker here talking to us about an experiment utilizing the insights of mechanism design to motivate health behaviors. And Dr. Ariel Zucker is an assistant professor in the Department of Economics at UC Santa Cruz, and her research studies policies to improve health and environmental conditions among the underserved communities worldwide. Many of her projects focus on countering behavioral biases in personal decision-making, and prior to Santa Cruz, Dr. Zucker did a postdoc at UC Berkeley ARE and earned her PhD in economics from MIT. And so we will have Ariel talking to us for about 40 minutes, and for our audience, if you have any questions for Ariel during the talk, please enter them in the chat box and I will come to them at the end. You can also raise your hand if you want to speak up directly and ask questions, and we can unmute you here. So without further ado, Ariel, over to you.
Okay, great. So thank you for the introduction, and thank you for having me. So as Shinan said, I'm going to be presenting work on using mechanism design to personalize healthcare. And I'll be presenting evidence on that from an experiment that I ran with my co-author, Rebecca Deason-Ross, who is at the University of Chicago in India a few years ago now. We started before COVID, and then it had to shut down for a while, and we had a few more people to enroll after COVID. So it was a long experiment, and I'm excited to present really the full results. That didn't work. Okay, great. So the starting point and motivation for this project is that there's a lot of potential to personalize policies, policies of all sorts, based on how people will respond to different variants of a particular policy. So you can imagine, personalized medicine as a sort of leading example. But for particular types of policies that are vertically differentiated in the sense that kind of everyone likes one of those policies, a challenge arises in personalization. And that's because if all of the people that you're trying to assign the different policy variants to prefer one of those variants that's sort of at the top of your vertical stack, then the people you're trying to target the policy at might not want the same policy that you think is best for them. And when you can't directly observe what people will respond to which policy best and just only give them one option, it can be really difficult to assign people to the correct policy variant. Okay. Luckily, there's a whole field of economics that studies this type of problem, and that's the field of mechanism design. And the field of mechanism design is all about assigning personalized policies or prices to people when you don't know exactly the details of which policy or which price is best for each person. And mechanism design offers two broad strategies for personalizing policies in these types of settings, where what the person assigning the policy wants is potentially different from what the people who are being assigned the policy want. So the first option is to offer a menu of choices over policy variants and let the people choose the one that they want. But instead of having them fully vertically differentiated, where one is the one where everyone wants, you kind of tweak the policies such that some people will actually prefer each of those variants. Okay, and this is analogous to second-degree price discrimination if you're trying to personalize prices. And the other option is you don't maybe observe exactly how people will respond to each policy, and that's what we would call the behavioral response type. But instead, you might observe something about people that's a signal of how they may respond to these policies. And so you can, what I'll call tag people based on something that you do observe and assign the policies based on that proxy, okay? So you can offer a choice or you can tag based on observables. Tagging based on observables when you're assigning prices is what we call third-degree price discrimination. Okay, so theoretically, there's a ton of work showing that these two approaches can allow a policymaker to assign different policy variants, even if they don't know exactly how each individual person will respond to the policies. But there's actually not very much work seeing how well these strategies can work in practice, especially for policy assignment. And so in this paper, we're going to actually do these strategies and ask two main research questions. So the first thing we're going to ask is whether we can personalize policies using these mechanism to design approaches to improve policy effectiveness. And second, we'll look at what channels contribute to the success of personalization in our particular context. And our context is why probably I'm presenting today. So we're looking at policies to promote lifestyle change to mitigate lifestyle diseases or diseases like diabetes and hypertension that are associated with basic everyday behaviors. And these are huge and exploding health issues all over the world, but especially in Asia. In our context in India, it's estimated that about a quarter of adults have hypertension and about a tenth of adults have diabetes. And the rate of growth in these rates is quite steep. So these are actually pre-COVID estimates, and I would be very shocked if it were not higher than this today. So it's a really big problem, and it's widely agreed that the solution is to encourage behavior change, and in particular to get people to improve their diets and to get regular exercise. So within this context, we're going to study a pretty common policy tool that people use to improve exercise and increase regular exercise behavior, and that's just to pay people for hitting daily step targets. And this is pretty common. A lot of insurance companies do it, some governments do it, a lot of workplaces do it. But usually when they do it, they just assign a single step target. And a potential strategy to improve these types of step target incentives is to, instead of assigning everyone the same step target, personalize the step target. So that's what we're going to try and do. And to sort of set the stage, we're going to think of the effectiveness or the thing that we're trying to maximize to be from the policymaker's perspective. So if I imagine I'm a firm or an insurance company, what I want is to increase healthcare savings or health benefits for my workers. And we're going to proxy that by basically how many steps people take. So we want to maximize that, but we also don't want to be paying people huge amounts of money to hit these step targets. So it's some balance between increasing steps and reducing payments. Okay. And we kind of assume that it's likely that different step targets are better for different people, and in particular, there are some people for whom a higher step target is better. But because these are vertically differentiated contracts, and what I mean by that is everyone is going to want the lower step target if they're rational, because for a given payment level, it's just easier to get that payment if you have a lower step target. So then you've got this vertical differentiation where the high step targets kind of look like a bad deal from the agent's perspective. And so you have this tension between what the policymaker wants and what the individuals who you're trying to assign the step targets want. Okay, so I was just asking who is in the audience, and so for some people, I think some of this talk about price discrimination and mechanism design is a bit jargony. So I am going to try and explain it, and if you're and feel free to pop some questions in the chat as I go through. Okay, so what is price discrimination, and how does it work in our setting? So first, I'll talk about how price discrimination and how the mechanism, what the mechanism design framework has to say about personalization using kind of the leading example of price discrimination. So let's imagine that I'm a bar owner and I have two types of customers. I have some hipster yuppie types who are willing to pay a lot for drinks and really like drinks and they like their drinks to be nice. And then I have some other customers, maybe they're mostly senior citizens who are not so willing to pay for they are not willing to pay as much for their drinks. Okay, and I, as a bar owner, I want to charge these hipsters really high prices, but I don't want to charge such high prices in general that my elderly low willingness to pay customers don't show up. Okay, so the solution is to try and personalize prices, and we have these two strategies: the choice and the tag strategy that I mentioned before. So the choice strategy is something like offering a menu of different prices where the prices are connected to some other aspect of the drink. So like an early bird special, it's going to be cheaper, but only if you show up in the afternoon. And then if you want to show up at the really nice time in the evening, you're going to have to pay the high price. Okay, so I give people a choice. They can show up whenever they want. And my hope is that the yuppies are going to show up in the evening and pay the high prices, and the senior citizens don't mind so much coming at a less desirable time if they can get the lower price. Okay, the other option is the tag option. This is third degree price discrimination. This is just offering a discount based on something I observe about the people. So I might observe that the seniors have an ID card that says that they were born a long time ago. And so I can target prices based on that observable, even if it doesn't 100% perfectly correlate to the willingness to pay. Okay, there might be some people who either get a fake senior citizen ID or are very wealthy seniors who love to pay for the nicest drink. So the challenges that you get from this are when the high types try and imitate the low types, and that's what you're trying to avoid. You're trying to avoid having everyone come in for the low priced drinks. Okay, so that's how mechanism design works for prices. How about with walking incentives? So we're gonna do something very analogous. Imagine that we have two types of walkers, a high and a low walker type, but I can't just observe who's who. And I want to get both of these types to walk more. And so I want to personalize the step targets. So I'm going to have these same two options. What we're going to do, and there are a lot of ways you could do this, is for our choice approach, we're going to offer a menu of contracts with different step targets. And the lower step targets are going to pay lower incentives, and the higher step targets are going to pay higher incentives. And people can then choose whether they want an easy step target that doesn't give them as much money, or a harder step target, but they get more money if they achieve it. So that's the choice approach. The tag approach is to assign the lower step targets to people that we predict will walk less based on, and will respond therefore better to a lower step target based on something that we observe about them. And again, the challenge is going to come when the people who would respond well to a higher step target try and imitate the people who would respond better to a lower step target in order to get an easy step target and get easy money. Okay, so how does this challenge potentially play out? Well, in the choice approach, imagine that we don't pay enough for that high step target, then the high types will be like, oh, it's not worth it, and they'll just go for the lower step target. On the other hand, if we pay too much for the high types, then we're for the high step target, we're wasting money. Okay, and in the tag, the concern that you might have is that the tag that we're going to end up using, which is the best and actually really only tag that we could think of, which was how much people walked in a pre-period before we assigned the contracts. Problem here is that that's highly manipulable. And so the high types might just act like they are very low walking types and very, very rarely go outside, and it would be very hard for them to hit a high step target in order to get the easy step target. Okay, so those are our two approaches. We're going to test those approaches in a randomized experiment where we're offering incentives for walking to a large number of adults, total of 6,000, more than 6,000 that we enrolled in the full experiment over time. And we're going to specifically target adults who have either a hypertension or diabetes diagnosis or elevated blood pressure or blood sugar. And we use this experiment to answer two research questions. We're going to test whether we can get people to walk more by personalizing incentives with either the choice menu or the tagging on observables approach. And then we're going to examine which channels actually contribute to the effectiveness of the personalization mechanisms. Check the time. Okay, great. Okay, so what do we find? The key takeaway is that personalization works. Both the choice and the tag approach increase the treatment effect of step target incentives by about 75%, and they do that without increasing costs. And moreover, the gains are seen over the entire distribution of walkers. Okay, so it's not just the low walkers or the high walker types. Everybody seems to do better under personalization. We find that the tag works well because it is pretty good at sorting people into the right contract. Okay, so it does turn out that lower step targets are better for people who walk less at baseline, and it is true that higher walkers. And it's also true that sorry, I said that a little bit wrong. So there are two reasons why the tag works. So the first is that that indeed lower step targets work better for lower walkers, and higher step targets work better for higher walkers. But moreover, we don't see what we might have expected, which is that those high walkers are trying to imitate the low walkers. Okay, so we don't see the people trying to get the easy step targets. Okay, similarly in the choice group, we get pretty good sorting of people into step targets that are more effective for them. As you might expect in a sort of standard economic rational model, because the high step targets pay more, the high walkers view them as worthwhile and choose those higher targets. We also see that some people are choosing those high step targets not just for the financial incentives that you would expect in a sort of standard rational economic model, but that many of the high walkers are choosing the high step targets because they actually want to walk more. And so they have basically no motive to imitate the low types. Okay. So there are some sort of standard expected things and some non-standard things, and in particular, that the high types are really not trying to imitate the low types in our setting. Okay, and the kind of main takeaway there is that personalization might work particularly well in settings where the policy is encouraging the types of behaviors that participants also want to achieve. And it can kind of lessen some of this tension that I've been talking about, where the high types are trying to imitate the low types because they just want easy money. If you're in a setting where the high types actually are trying to get something a little bit more similar to what the policymaker wants, if they want to be healthier than they are, then you'll have less of this concern. I'm going to skip the related literature and just launch into the rest of the talk. So I'm going to talk a little bit more about the particular context where we are, where we're working, and why we chose to do this project. And then I'll explain the design of our experiment. And then I'll go through the results, and then I'll finish up. Okay, So why do we try and do this evaluation? We actually started this project after we did a previous evaluation of step target incentives in nearly the same context. And so in a previous paper, we recruited a bunch of adults who also either were diabetic or had elevated blood sugar. So we didn't include people based on hypertension. That was kind of the only big difference. And we recruited these people in a city, the same city in Tamil Nadu, India, where we conducted this project. And we tested out incentives for hitting step targets over a slightly longer intervention period than this one. But we paid people for 12 weeks to hit a step target. And we had three main treatment groups in that project. The first treatment group, we paid people to hit a daily step target of 10,000 steps, which is kind of the standard step target that you see tried in projects like this. And we'd paid people 20 rupees in financial incentives every day that they hit that step target. Then we had two main comparison groups, a sort of what we called the monitoring group to understand the impacts on exercise. So for this group, we gave them a pedometer to measure their steps and a step target, but we didn't pay them for hitting a step target. So that could help us isolate the effect of incentives on walking. And then we had a large peer control group that didn't get any pedometer, and we didn't have to go through the trouble of measuring their walking. And that was a large group so that we could understand the health effects of the incentive treatment. So when we did this experiment, what we found was that the incentives were effective at getting people to walk more. So if we compare the monitoring group who had no incentive in yellow to the incentives group in red, we can see that way more of the incentives group exceeded the 10,000 step target, and that their average walking was about 1,300 steps more per day than people who weren't getting paid. So it was working pretty well. And it had big
Ariel,
health effects. Yeah.
can I ask a clarifying question? So does the
Yeah.
monitoring group also have a target and only the difference is it do not have financial incentives?
Yes, exactly. So
Okay.
just because we've just wanted to, for that group, isolate the effect of incentives, we gave them the same step target, but it was like just verbally, hey, doctors say hitting 10,000 steps is good for you.
Mhm. Okay.
And then when we compare, but it was a pretty small group, so we couldn't measure health outcomes relative to that group. We didn't have power for that. But we had a large group that I'm showing here that didn't have a step target, didn't have a pedometer. And compared to those people, the people who had incentives had positive impacts on their health. So you can see that compared to this pure control, giving people a 10,000 step target reduced a sort of index of blood sugar outcomes and an overall index of metabolic health. And this is especially true in the two bars on the right, where we focus on the portion of the sample that had above median HbA1c at baseline. Okay, so this is all to say that it was pretty effective on both getting people to walk more and to improve the people's health. But even so, what we could see was that we could do better. So if we looked at just the walking in the monitoring group over the intervention period, we could see that a bunch of people over on the right were basically walking 10,000 steps a day on average with no incentive. And so we looked at this distribution of how the monitoring group with no incentive was doing, and we thought there are a lot of people who should be getting a higher step target so that they can walk even more and have larger health effects. So that was really our starting point, was looking at this distribution and thinking, how do we get these guys on the right to also walk more? Okay, so then we designed this whole experiment to figure out a way to do that. So we recruited about 6,000 people in these public screening camps that we set up all over Coimbatore, this sort of mid-sized city in Tamil Nadu in southern India, where we measured blood sugar and blood pressure. And if people were interested in in our experiment and had elevated blood sugar, blood pressure, we invited them to participate. Okay, and then to measure the impact of our interventions on walking, we measured walking using Fitbit Zip pedometers like the one this guy is wearing. And I won't talk about it today, but we did a lot of things to try and make sure that people were not cheating with their Fitbits, and that this was a pretty good proxy for daily exercise. Okay, so among our sample, we have 4 main treatment groups. First, we have the treatment groups where we personalize step targets. And I've already talked about the overall approach, but to be very specific, in the choice group, we had a menu of step target contracts where the 3 step targets people could choose from were 14,000, 12,000, and 10,000 steps. And the high step target paid 20 rupees, so 14,000 steps paid 20 rupees, but then the lower step targets paid less, successively 2 rupees less per day as the step target was lowered. Okay, and so we just let people choose the one they preferred, and then they would be asked to hit that target. Okay, then the second group, the tag group, we assigned the same 3 step targets, 10, 12, and 14,000, but we assigned it based on average walking for about 1 week before we assigned the step target incentives. Okay, and in this case, all 3 of the step targets paid 20 rupees. So those are our main personalization groups. To understand the effect of personalization, our main comparison group is going to involve people for whom we just randomly assigned those 3 step targets, 10, 12, or 14,000, all paying 20 rupees per day if the step target was achieved. And since we wanted at least one of those treatment groups, one of those step targets to be large enough that we could use it as our main comparison, most people were assigned to the 12,000 step target. But we still have a bunch of people in all 3 of these step targets. So I'll show some graphs where I'm just comparing to the 12,000 step target. Okay, and then finally, just to benchmark how big was the personalization effect relative to the effect of non-personalized incentives, we have again a monitoring group where people got a Fitbit but no incentive. So then we can say, okay, what's the effect of non-personalized incentives, and then how much bigger is the effect of personalized incentives? You might be wondering how we actually came up with these 3 step targets and those amounts that we paid. And this is, again, a place where our previous intervention that we had conducted in a similar sample came in handy a lot. Okay, so we had a previous evaluation where we just assigned contracts only with a 10,000 step target. And so what we did is we said, okay, what do the treatment effects look like relative to how much people walked at baseline in that experiment? And we saw that it had this sort of inverted U shape. So it was working the best for people whose average baseline steps were at 4,500, right at the first vertical line. And so we said, okay, it's working the best for people who are walking 4,500 steps at baseline when we assign a 10,000 step target. Let's just assume that everybody's optimal step target is about 5,500 steps above their baseline walking. Okay, so that was our model for everyone's optimal step target is it's your baseline walking plus 5,500 steps. And then what we did is we split the walking distribution that we had from the previous experiment into 3 bins of approximately equal size, and assigned the average optimal target with a bunch of rounding to those 3 bins. Okay, so it was a little hand wavy, but it was based on some existing data.
So Ariel?
Yeah.
Before we move on, we have another clarifying questions from the audience. So can you explain again what's the difference between tagged and fixed?
Between tag and fixed?
Between tag and fixed, yeah.
Yeah, absolutely. So in the tag group, we first measure baseline walking, and then we assign the step target according to how much people walked in the initial baseline period. Whereas for the fixed step target, we just randomly assign the 3 step targets. It has nothing to do with how people behave. Okay, so how did we decide the choice menu? Well, we wanted to use the same 3 step targets, and then we just sort of piloted asking people, what would you choose if they paid different amounts, and we found that even just a 2 rupee difference was enough to get lots of people to choose even the very high target. So again, it was pretty ad hoc, but we had some data to try and decide which menu to offer people and what prices we would pay people. Okay, this might clarify a little bit more the difference between the treatment groups. So in terms of the timeline, how we actually assign these groups, the first thing we did was, we conducted a baseline survey where we collected a lot of information about people. A key thing about how we did the experiment was right after the baseline survey, we told the tag group exactly how the target will be assigned. So we told them, if you walk more, you're going to get a higher step target. And we told them exactly how much more they had to walk to get each step target. Okay. Everyone else, we just said, please walk for a week. And we let everyone go off and walk for a 6-day contract period, where we monitored everybody's walking, tag group and everyone. And then we came back after 6 days on day 7 and actually launched the actual experiment. Okay, so on day 7, for the tag group, we looked at their baseline walking in that first 6 days and assigned the contract based on how much they walked. Everyone else got to choose between different menu options. And then once we had collected everyone's choices, then we randomized, okay, are you in the choice group? And if they were in the choice group, then we assigned them based on their choices. And otherwise, we either randomly assigned them to get one of the 3 step targets and be in the fixed group, or to be in the monitoring group and get no incentive, but they got to keep their Fitbit for the contract period, which we shortened to 4 weeks. So it's a pretty short contract period, where we paid people every single day that they hit their step target. Okay, so the key thing to note here is that, or key things to note here is that we have baseline walking data for everyone, but in the tag group, they might have responded already to knowing how their target would be assigned. And also we have choice data for everyone, which is just nice because we have a whole lot of choice data, even for people for whom we didn't end up assigning them based on the choices that they made. Just to kind of give you a sense of who these people are, they're about, the average age is about 50 years old. So we did screen out very young people, focused on people who are at least 40. And most of them or not most of them, but many of them are diagnosed with diabetes or hypertension previously. And that was, a key way that we got people into our sample. So a lot of them have a diagnosis of either diabetes or hypertension. So these are people who, many of them already know that they probably should be exercising more. Okay, so next I'm going to go through the results. Check the time again. So sorry, I thought it was an hour, so I am not planning to be done in 6 minutes. I hope that's all right.
Yeah, that's fine.
Okay, great. Okay. Excellent. So let me go through the results and show you guys what I found, or what we found. Okay, so the first thing we found has to do with just the fixed step targets. Okay, so we're just focusing on the step targets that were randomly assigned. And those definitely increased walking. So in yellow, we've got the people who had no payments for hitting a step target. And then the 3 blue bars show the 10, 12, and 14,000 step targets. And you can see that they're all quite a bit higher than the monitoring group, and by about 600 steps per day. Okay, so we get a treatment effect. They all look like they have approximately the same effect, and they improve walking. It's not huge, but they're definitely working. And you might be looking at those bars and thinking that they look really, really similar. Is anyone even paying attention to the step target at all? And actually they are. So if you break these down into histograms of daily steps that people took in the contract period, you can see that in light blue, the guys who are assigned the 10,000 step target, their daily walking bunches right beyond the 10,000 step target mark. People, on the other hand, assigned the 12,000 step target, their daily walking bunches right above the 12,000 step target mark. And in the 14,000 step target, similarly, daily walking is bunching right above 14,000. So people are definitely responding to the step targets, even if they look kind of similar on average. Day to day, they look really different. Okay, so those are the histograms of walking in the 3 step targets. Okay, so the fixed step targets work. They get people to walk more. What about personalizing the step target? The sort of first main research question we had was just whether this worked at all, and this is just a simple chart showing that it does. Okay, so the tag group is in orange, the choice group is in red, and you can see that daily steps in the contract period are about 1,100 steps more than the monitoring group per day in both tag and choice, whereas the 3 fixed step targets were only about 600 steps or 6 minutes per day higher than the monitoring group. So instead of a 6-minute increase, we get a roughly 10 or 11-minute increase in walking per day. So it's a pretty big marginal impact. It increases the total effect size by about 75% once we personalize step targets. So that was pretty exciting. You might have noticed that, the 12,000 step target, I was just showing you that just relative to the 12,000 step target, 12,000 step target wasn't the most effective on average of the 3 randomly assigned step targets. But the effect of personalization is not driven by just randomly assigning some people to the more effective step targets. So if you reweight the 3 randomly assigned or fixed step targets to match the personalized groups, personalization is still way better. So on the left, comparing tag to the fixed groups reweighted such that they're in the same proportion of how the tag ended up, you can see that tag is still statistically significantly better. And same with the choice on the right. Reweighting the 3 fixed groups in the same proportion that people chose them still doesn't do as well as actually letting people choose their step targets themselves in a non-random way. Okay, so it's definitely not just randomly assigning step targets. It's people sorting appropriately. Okay. Another thing that was really exciting to us is that the choice and the tag are not just effective, they're also cost effective. So if we look at on the x-axis, the average daily payment, and on the y-axis, the average daily steps in each of the randomly assigned groups, you can see that, okay, people are walking about the same amount in all of the random groups. The tag and the choice, of course, they're above, people are walking more, but moreover, we're not really paying them more. They're getting paid on average the same amount as the 12,000 step target and substantially less than the 10,000 step target. So we're relative to the 10 and the 12,000 step target, we're getting people to walk more without actually paying them more on average. The 14,000 step target is cheaper, but it doesn't actually get people to walk very much more. But if you had a very strict budget, it's perhaps possible that the 14,000 might be a decent choice. But there are other downsides to just assigning a fixed step target that the tag and the choice do better at. And that is that they really move the whole distribution of walking rather than targeting a certain set of people. So here I'm plotting an empirical CDF of walking in each of the 3 randomly assigned step targets. And you can see that at the bottom of the distribution in light blue, the 10,000 step target is really helping move people over. So there are very few people walking very few steps. in the 10,000 step target, whereas the 12 and the 14,000 step target, they're too high. For people who are really low walkers, they just ignore those step targets. So at the bottom, the 10K is really effective and the other ones are not. And it's the opposite at the top of the distribution. So at the top of the distribution, the 14K step target is really moving the high walkers over, but the 10K is doing nothing. On the other hand, I'm just dropping the 12K out, if we compare these two extreme fixed step targets to the personalized step targets, we can see that at the bottom, choice and tag are similar to 10K. They're getting the low walkers over. And at the top, they're similar to 14K. They're also getting the high walkers over. Okay, so the 14K may be really cheap, but it's partly because it's not moving everyone. It's only moving a few people. Choice and tag really effectively move everyone. Okay, so far we've seen that choice and tag are effective. They lead to big increases in steps. They're cost effective, at least relative to the 10 and 12,000 K step targets. And in fact, they first order stochastically dominate any of the fixed step targets. They move the whole distribution of walking to the right. Okay, why is this? Why do they work so well, even though we kind of had ad hoc, it was somewhat ad hoc how we designed these interventions. Let's focus on tag first. So the way the tag works is that it assigns treatments based on how much people walk at baseline. And there are really just two ingredients that we need for this to work. The first thing is that it has to successfully sort people into the more effective step targets. So we need people with low baseline walking to actually be the people for whom lower step targets work well, and high baseline walkers to be the people for whom the high step targets work well. The second thing we need for the manipulation that might be going on when people hear, oh, if I walk a lot, I'm going to get a high step target. And if I leave my Fitbit at home, I'll get a low step target. We need that manipulation to not undo any successful targeting in our tag. So we're going to look at each of those. So this is showing that the first ingredient is definitely there, that the higher step targets are indeed better for the people who walked more at baseline, and lower step targets for people who walked less. So this is plotting the treatment effect on steps of each of the three step targets based on the tercile of baseline walking. And this is using the randomly assigned steps. So there's no manipulation here. This is just when we randomly assign steps, how well does each step target do based on how much people walk at baseline. And you can see that for people in the bottom tercile of walking, the 10,000 step target in light blue is most effective. And in the middle tercile, the 12,000 step target is most effective. And in the top tercile of baseline walking, the 14,000 step target is most effective. Okay, so that was what we had planned, bin up people into 3 bins, assign the step target based on the bins, and it looks like that was correct if we were ignoring the potential for manipulation. But what if people manipulate? And they very well might, and we wanted to make it salient that they could, since we thought in the real world people would figure out the assignment algorithm, and we wanted to know whether this would be a big problem in the real world. And so, we told people exactly how the tag algorithm would be assigned. And we knew that rational economic theory predicts that the higher step targets are not desirable, that the low step targets are people's favorite. Okay, so we expected participants to manipulate their baseline walking downward to get those lower step targets. And we wanted to see, is that a big problem? And so the way we looked at that was we compared baseline walking for the people who were in the tag group to baseline walking for people who had no incentive to manipulate. That is everyone else. Okay, so if we look at baseline walking, a histogram of baseline walking, For the people who are not in the tag group, who had no incentive to manipulate, it looks like this. Okay, and if we compare that to baseline walking in the tag sample, what we want to see is whether there's manipulation around the two thresholds, which are the red lines, to get into the different step targets. And we do see some evidence of that type of manipulation, but it's definitely not people trying to walk less. Instead, what we see is that it looks like people are walking more to get the higher step targets. And so if you look at the first thresholds, you get the 12,000 step target. There's a discontinuity in orange in the tag group of people walking just above the cutoff to get the higher step target. And there's something sort of similar going on at the far right of the baseline walking distribution, where a bunch of people in the tag group have very high baseline walking in a way that leads to far more of the tag group being assigned the 14,000 step target than we would have seen if we had assigned those step targets without any manipulation incentive to people who had no incentive to manipulate in the blue. Okay, so if you look at the targets we assigned to the actual tag group in orange and compare them to the targets we would have assigned the people who had no incentive to manipulate, you can see we're assigning way more 14,000 step targets. Okay, totally the opposite of what we expected, where we expected to be assigning way more 10,000 step targets. Okay, so that was not what we expected. It looks like people actually want higher step targets and don't want to do the easy step targets. So the next question we had was, does this manipulation, we thought it would be undoing the effectiveness of the tag. Does it instead improve the effectiveness of the tag? So if we compare the people in the tag to people who just were randomly assigned to their tag step target in the fixed step target groups, we can actually see what was the total effect of the manipulation. And so comparing the people in orange in the actual tag to the people in blue who are randomly assigned their tag algorithm step target, we can see that, you know, the tag actually does slightly better. It's not statistically significant, but overall that manipulation, instead of undoing the effect of the tag, is, if anything, actually improving the effectiveness of the tag. Okay, so why don't we see manipulation downwards? There are a bunch of reasons why this could be. Could be that, you know, people would feel bad manipulating. It might feel like lying. People might just be excited, or they might want to, you know, look good for the experimenter, and they think that we want them to have a high step target. A key reason that we think people want to walk more is that they might be present biased, and therefore they are engaging in fewer health behaviors than they would like to. And so they might demand commitment contracts to get them to walk more in the future. And to test that, we also get preferences over a menu of contracts where all the 3 step targets pay the same amount. So the only reason that you would choose a higher step target is because you actually want to walk more. And what we find is that when we offer those choices, there are about 30% of people who choose the higher step targets even when they don't pay more. So it does look like people have a motive to get themselves to walk more, completely separate from the financial motive of the higher higher step targets paying more. And so it does seem like, you know, even without a cost of a manipulation cost or anything like that, some people really prefer the high step targets because they will walk more under them. Okay, so tag works in part because the tag mechanism we designed was not crazy, and in part because people actually help us a little bit by self-sorting into contracts that are better for them. What about the choice? So in a sort of simple rational economic model, you would imagine that choice operates through sorting in 3 steps. So first, participants should be sorting between the 3-step targets based on their walking type. But they're doing it in a sort of simple rational economic model as a result of just these financial mechanisms to sort. Remember, in the choice menu, the higher step targets pay more. And they should have some good information about their own type, right? So they should know that, oh, I'm going to respond to the higher step target and be able to achieve it, versus someone else will have to know that, oh, the low step target is good for me. If they don't have that information about their own type, then their choices are not going to be very good. Okay, so if we have those 3 ingredients, then the sorting and choice should work. Okay, so we're going to look at each of these 3 channels, whether people sort based on walking type, whether they care about financial incentives, and whether they have information about their own type. So the first thing to show is that people sort based on the best proxy that we have of walking type, which is, again, their baseline walking levels. So on the x-axis here, I've got average baseline steps among the choice participants. And then on the y-axis, we've got a bar chart of the percent of people whose baseline walking fell into each bin who are choosing each of the 3 steps, where the darkest blue is the 14K and the lightest blue is the 10K. And what we can see is that as we move right, as average baseline steps get higher, far more people are choosing the 14,000 step target. And as we move left, in general, far more people are choosing the 10,000 step target. And in the middle, people are kind of choosing the 12,000 step target a little bit more. Okay, so the sorting is definitely happening, and it's happening based on our best, a good proxy of the effectiveness of the 3 contracts, where the people with the highest step targets, highest baseline walking, are choosing the highest step targets, and vice versa. We also machine learned the predicted treatment effect of the 14 versus the 10,000 step target, and we can see that that's also fairly predictive of people's choices. So we machine learn this based on all of the observables in our data. And so, it's not just baseline walking that goes into this prediction. So it is sort of another way of showing that people are choosing in a way that makes sense. Okay, so we see that people are choosing based on which step target is most effective for them. The next question is, how much of a role are financial incentives playing in that? We already showed that sometimes people actually want higher step targets. And so another question is here, how much do we really need these incentives to sort people? So the way we tested this is we had actually 3 different choice menus where people could choose between of them. The main one that I've been talking about, where the 3 step targets were differentiated only by a 2 rupee payment. But then we also had another choice where all of the 3 targets paid the same amount. They all paid 20 rupees, and another one where they had even larger differences of 10, 15, and 20 rupees. So we can compare across these 3 choices to see whether people change their choices between the step targets a lot when the differential payment between those step targets got larger. And what we find is that choices changed a little bit, but not a whole lot. So this is plotting the fraction of people choosing each of the 3 step targets based on the 3 menus. So in orange, all of the 3 step targets pay the same. And in purple on the left, they have the largest price differential. It's 5 rupees different between the 3 step targets. And you can see that choices are changing a little. People are choosing the 14,000 step target less often if it doesn't pay any more, but it doesn't make a huge difference. Okay, so again, we're seeing, yeah, prices matter, But even when they all pay the same thing, some people are still choosing that 14,000 step target. Okay. The last thing that we look at, and I think I'll skip over this in the interest of time and detail, is that we need people to know something about their own choice for this to work. And so, we already know that they must have had information about which step target is going to work best for them, or else they wouldn't have separated based on the predicted treatment effects in the first step. But an open question that we had was whether more information would have made it work better. The short answer is we didn't find any evidence of that. The way we tested it is that we gave some people a longer period with their Fitbits before allowing them to choose their step target, and that didn't seem to impact anything at all. So information is playing a role, but it's surprisingly, people already have pretty good information about which step target is going to work well for them. After just a week of walking with the Fitbit, they don't need additional time to learn more about which step target is going to be better for them. Okay, so I'll sort of end on that note. All of the personalization treatments that we tried worked quite surprisingly to us. We really thought this was going to be a lot harder to do than it was. We tried these two strategies, and both of them led to an increase in the effective step target incentives by more than 75%. Okay, and it worked across the whole distribution for lows and for highs, and everybody's walking more, which was really exciting. And there are really two overall, reasons that things worked. One is just the standard reasons, the standard economic reasons, where, it was kind of difficult maybe to leave your Fitbit at home, and the same way it might be kind of difficult to get a fake senior citizen ID to get the early bird special or something like that. And similarly, people do care about getting paid more, and so people respond to the incentive to have to choose a 14,000 step target rather than a 10,000 step target, only if they're able to hit that 14,000 step target. So the sort of standard rational things are going on. But then the second thing is going on, that the people who can hit that high 14,000 step target, they actually want to hit it. And so they're not trying so much to pretend that they're going to do better in the easy 10,000 step target. People really want to walk more in this setting, and it's allowing these personalization strategies to work quite smoothly. And so I think a key takeaway is that, especially in settings where what looks like vertical differentiation between the contracts is not as vertical as we might think, because the people in your sample also want to do the thing that you want them to do, then these types of mechanisms for personalization are especially effective. And so in our setting, we think people want to walk more than they are. They know that they will be motivated by the incentive in a way that they wouldn't be able to motivate themselves. And so they self-select into the incentive that they think will be most effective for them, rather than the one that they think is going to give them the most money for the least amount of effort. So that's it. I will be sticking around for questions, and thanks a lot.
Yeah. Thanks, Ariel. Thanks for sharing your very insightful and policy relevant research. So we're going to have some stretch at the end to address some of the questions. So for our audience, if you do have questions, you can put them in the chat box or raise your hand, and I can bring you to the panelist. And for those of our audience, if you need to leave, like you can keep an eye on our recordings to hear our discussion at the end. So I think to start, I do want to like ask one question. You've discussed a bit at the end where like there are different reasons why this might work particularly well in this setting. But I feel that in general, both for like people working in economics or public health, it's perceived very difficult to change people's behavior, right? Either for diet, for exercise. An example would be like you skip the literature part, but I know you must be familiar with like the work by Ben Handel and Ted Miguel and co-authors about commitment devices for chronic condition patients in India, right? And like what they found there is like mainly like nothing works, and like even for those sophisticated patients, it does not really work, right? And
Totally.
so what do you think like make things work particularly well in this particular setting? Because you also say that it's like more of a commitment device flavor, right? Not necessarily
Yes.
about the financial incentives. Yeah, can you say something about that?
Yeah, that is, yeah, it's a great point. So there are a few things that you've mentioned. One is kind of the idea that it might be easier to change diet than to change exercise. I think it's actually hard to change both diet and exercise. It's very hard to design an incentive program to change diet because it's very hard to monitor. So that is not to say that we should not be encouraging people to do both of those things. So maybe to part one, like I think both are important and both are kind of difficult to change. A lot of the difficulty in getting people to walk more is in making it a permanent change once you take the incentive away. And so typically once you take the program away, people's walking levels kind of slowly return back to normal over a period of maybe a year. So we actually looked at that in our previous experiment, and even 3 months out, there was still an effect, but it was definitely a smaller effect 3 months out. Yeah. So I think the challenge is, if you're like, do you just keep doing this incentives forever, which I think is actually not crazy because they're pretty cheap and this is pretty important. Or is there some way to actually get permanent behavior change? And I think that's a big area for future work. Is how do you kind of inculcate these habits more permanently? Okay, then the second part of your question is kind of about the, like, why did this seem to work even though it was partly commitment, and in other settings where people have looked at commitments to health behaviors, it hasn't been as successful. And I don't know the answer to that question, but I do have some guesses. So especially if you look at the Miguel and Rao, and there's at least one other person on that paper, work on the incentives for hypertension visits. They were paying people to show up at like 3 hypertension visits, and so it's like with a doctor. It's a very different thing than walking. And I think that probably a lot of the reason that they had so much more trouble than us is that we're incentivizing a behavior that people already do every single day. Everybody that can walk is walking, and they're incentivizing a behavior that people have never tried before. So if you try to commit your future self to do a behavior that you haven't tried before, and they're letting people kind of choose, like, how much do you think you'll need to pay yourself to convince yourself to do the thing? I think the information issue about how much will I need to be paid, how hard is this going to be in the future, is a much bigger concern. Whereas in our setting, I think people actually knew pretty well like which step target is going to be best for them. And so I think there's a really big difference between their work and our work because the behavior is much more familiar. So so that's just that's just a particular paper. I mean, there are lots of papers that have shown commitment mechanisms working in other settings.
Right.
Sometimes they work, sometimes they don't. And my guess is that a big difference between the settings where they work and they don't is sort of the information.
Yeah. Yeah, I totally agree. And I feel that like those kind of behavioral biases and in chronic condition management is like often seen as like one of the biggest challenges is faced by patients themselves and from the like providers or social planners perspective, right? We want to help people to overcome that. And then like I think a quick thought related to that, I guess I'm also thinking about people's perception about the health production function, right? How does like walking and seeing a doctor come into the health
Yeah,
production function, right? Probably there's some difference there as well. If they perceive the benefits
great.
of walking to be very high, but like they overlook the benefit of seeing a doctor, then that's probably
Yeah, it's a very good
yeah,
point. Right. There's
right.
both the people might not understand. There's much less talk in the sort of general air about, oh, it's really important to see a doctor. Like,
Yeah,
it's kind of hard to conceptualize what the benefit is going to be.
right.
I see a couple of
Yeah,
questions in the
questions.
chat. Can I do this?
Right.
Okay. Okay, so there are a few of these. I'll start with Tushar Ahmed about whether there is any difference of the incentive treatment effect based on other things that we observe about people like age, gender, education. So yes, um, I don't remember exactly how they all work. There's not much with gender, and not a whole lot with education. We collected a sort of wealth index, an asset index, and poor people do respond more to incentives. So that's a clear one. Especially the higher step targets, they're willing to make the effort to walk more. And I think they're really for poorer people in India, these are substantial incentives. And for wealthier people in India, they're not so substantial. And so maybe wealthier people are not willing to undergo the effort of hitting the 14,000 step target quite so much. So that was a key one that we did see that we didn't really think about that much, but makes total sense because India is a very, very unequal society. And so, the variance in socioeconomic status in our sample is very large compared to most of these types of studies. The other one is age. And I do think a key thing to note there is that age and steps have a kind of complicated relationship because as you get older, your steps get smaller, and so you take more of them. And so there's sort of an effect that we see where for for very the youngest people in the sample, the treatment effect is smaller, and then it kind of peaks, and then gets smaller again for very old people. But part of that is that walking for 10 minutes, if you're older, you're going to take more steps. So those are the two things we see.
Right. And you consider that as potentially the tags you can use, like observables, probably.
Yeah. I mean, I think that, well, for age, you might be, I think that age is one where you might be able to do so. I think that you'd have a lot of people question the ethical basis for tagging or for assigning based on wealth, especially because the way it would go would be you would be assigning to the poorest people to make the most effort for the least amount of money, and you'd paying wealthier people more because they don't care as much about the same amount of money. So for ethical reasons, totally. I'm not sure it's the best of things to tag on.
Right.
But I think for age was one that really did stand out as something that matters for steps, not necessarily for exercise, but specifically steps.
Yeah. There's a question from Castile from like, I guess, the dynamic whether the effect deteriorate over time.
Yeah, that's a great question. So we found kind of slightly different things in this program where we were only assigning for 4 weeks. There's kind of a really big spike in week 1 And then it's pretty steady over the second or the last 3 weeks, and it doesn't really decline very much. Um, I think I think it was maybe a little bit weird to do it for just 4 weeks. We mostly did it to save money so we could have a larger sample size. Um, when we did it for 12 weeks previously, it was pretty steady. The other thing that we found was that the health effects on like random blood sugar and HbA1c, they definitely increase over time. So that might just have something to do with the like how blood sugar responds to exercise, but there is a very, very, very clear pattern of increase in health impacts over time when we do it for 12 weeks and have kind of enough large enough control group to actually measure health impacts. In this experiment, the monitoring group is very, very small, and we didn't like look at health outcomes at regular intervals, mostly for financial reasons. So all of that information is from the previous experiment.
Right. And then there's another question about thinking about the experiment that Gautam Rao and other authors did on sleep in India. And what they did is like basically providing information regarding the benefits of more sleep, but they didn't find much of an impact. So do you expect that this kind of personal incentives would work in that context as well?
Yeah, that's such a great question, right? So that was another example where they had different kinds of contracts, and they were kind of incentivizing people to take different kinds of sleep breaks and get different types of sleep. And there was naps versus like better sleep at night and longer sleep at night. And the thing that really seemed to work well was napping, and now I try and nap at work all the time. So I love that experiment for giving me an excuse to nap in the middle of the day. Yeah, I think that the question there that I would have is again on kind of the knowledge side, because I think, most people that I know that read that paper were surprised that the naps were the most effective thing. And I think in that context where really most people probably don't know what kind of sleep they need, which might be a little bit different from the walking context. On the other hand, I think that that I could be wrong about that, and that people maybe do know what kind of sleep they need. Then some people might know that naps are better for them, and some other people might, or know they might have a good instinct that naps are probably better for them, and other people might know that other types of sleep interventions are better for them, and they probably want to be more productive and do better in their relationships and other workplaces, etc. And so you might see some amount of individual self-selection into the most effective sort of sleep treatments. So I do think that that's the type of place where it's certainly possible. But I think where it really, like other places where I expect to see more of this, would maybe be in questions of like weight loss, where most people who want to lose weight have tried to lose weight before, and they may have experimented with different strategies, and they might have a good sense of which strategies felt like they were working better for them and which were not working better for them. Or addiction like quitting smoking or something, you can try and get someone to quit cold turkey or sort of slowly scale it down. And I think that's another setting where people might have a better sense than their doctor about which one is actually going to work well for them. And it might be better to allow people some amount of like self-selection in figuring out, the best sort of treatment regimen.
Yeah, sounds great. I just feel like there's a lot of questions for us like researchers to answer, right? In terms of like changing behavior to improve health, because like such a critical part of like health in general.
Yeah.
Okay, so I don't think there are further questions in the chat. Yeah. So thanks, Ariel, again for sharing your work with us, and thank all of our audience for participating. and hope to be in touch with everyone for future webinars. And thank you all again.